Functional areas of the frontal lobe. So frontal lobe is mainly responsible for motor actions. That is, it controls the movements of the opposite half of the body. So it has 6 main functional areas. Among that, the first one is primary motor area. So this primary motor area is also called Brodmann's area 4 or somatomotor area 1. So it is situated. So for every functional area, what is the location? What is its function? What happens when it is damaged is very important. So precentral gyrus. So this is the precentral gyrus. What you are seeing here in front of the central sulcus. So this black line is the central sulcus. So in front of central sulcus, this is the precentral gyrus, and which extends onto the medial side. You can see in another image. So it is extending onto the medial side. This is called paracentral lobule, and this is anterior part. This is the posterior part of the paracentral lobule. So anterior part is motor and posterior part is sensory. Of course, it has very different function like defecation and micturition, but anterior part is also a part of the primary motor area. So paracentral lobule, anterior part. So the main large pyramidal cells called this Bedge cells will be there here in this cortex, and they are responsible for formation of corticospinal fibers and corticonuclear fibers. Spinal fibers, they go to the spinal cord, and from the spinal cord to the various muscles of upper limb, lower limb, trunk. Corticonuclear fibers, they relay in the cranial nerve nuclei in the lower part of the brain stem, and from there to the different muscles of head and neck region. So these movements of all head and neck region and upper limb, lower limbs are controlled by the primary motor area, that is paracentral gyrus. So in human brain, the representation is inverted homunculus representation. So inverted homunculus means the entire body is represented upside down. So first on the medial side in the paracentral lobule you will see the foot, legs and thighs, and on the superior border you are seeing the perineum here, and on the upper part of the precentral gyrus you will see the trunk, and next comes the upper limb with very large representation of the hand, and then comes the face, tongue and pharynx. So pharynx is represented most lower, and this lower limb is represented on the medial side. So this is the inverted homunculus representation, and the proportional area is directly proportional not to the size of muscles or bulk of the muscles. It is not represented to the size of the muscle, but it is directly proportional to the actions, fine movements. So face and muscle shows the fine movements. So based on its activity, skill. So this is represented. That's why even though hand is very small, it is represented in larger area, and face also, though it is small, it is represented in very larger area. So this is about the primary motor area. So when there is damage to this area, it leads to hemiplegia, that is paralysis of opposite half of the body. So opposite half of the body do not function. So that is called paralysis or hemiplegia. Then comes the premotor area. So in front of the primary motor area, you can see this premotor area. So this is Brodmann's area 6. or somatomotor area 1, it is also included. Both are included in the somatomotor area 1. So this is present in the posterior parts of superior and middle and inferior frontal gyrus. So this is the frontal sulcus, superior frontal sulcus and inferior frontal sulcus. So this is the superior frontal gyrus, this is middle frontal gyrus, and this is the inferior frontal gyrus. So in the posterior parts of the superior, middle and inferior frontal gyrus, you will see the premotor area. So this is not equally present up and down. So above it is very broad, below it is very narrow. So this area is responsible for extrapyramidal fibers. That is, other than the pyramidal fibers which begin, that is corticospinal and corticonuclear fibers. Other than that, we have some fibers which go obviously to cerebellum through red nucleus and the olives. So these are called cortico-rubral fibers and cortico-olivary fibers. So these fibers begin in the cortex, go to the red nucleus and olives, and from there to the cerebellum. So these are called extrapyramidal fibers. So these fibers mainly responsible for tone, posture, coordination of movement. So this is helps in attaining the skills for the body, skill movements. So premotor area, it keeps the memories of past experience. So past, when you have done any work, it keeps the memory of the past work, and on repeated action of the same movement, it will be attained as a skill. So skillful movements are under the control of premotor area. When this area is damaged, of course, the skills will be lost for the person. Then next comes the frontal eye field. So this is the frontal eye field, which is situated in the middle frontal gyrus on the posterior aspect. Middle frontal gyrus on the posterior aspect. So this area, it helps in the control of movement of eyeballs. The conjugate movement of the eyeballs. That means if we want to see on the right side, both the eyes has to move towards the right side. If we want to see the left side, both eyes has to move onto the left side. This is conjugate movement of the eyeballs. So this is controlled by the frontal eye field. So this is Brodmann's area 8. This is 6 and this is 4. So this Brodmann's area 8 helps in the conjugate movements of the eyeball. When it is damaged, it leads to deviation of both eyes to the side of the lesion. So because of this, involuntary tracking movements is lost. Then comes Broca's speech area. So Broca's speech area is present in the lower part of the frontal lobe, that is the inferior frontal gyrus. So this is the inferior frontal gyrus, which is the area 44 and 45, and this is called pars triangularis. So this triangular area is called the pars triangularis. So which is present behind this is called the pars opercularis. So these are present around the horizontal and ascending sulcus of the lateral sulcus. So this is the lateral sulcus. So it has two rami, horizontal rami and the ascending rami. So these pars triangularis and pars opercularis surround this uh, sulci or this rami of lateral sulcus. This is very important for production of voice, that is vocal cords, uh, our mouth, lips, tongue, of course, the paranasal air sinuses, everything help in the vocalization, production of our voice. So muscular control of all this and production of voice is under the function of Broca's speech area, or it is also called motor speech area, because it is controlling the muscles which help in voice production. So when damage to this area occurs, it leads to aphasia, That is expressive speech is lost. So the patient cannot produce the voice. Though he can understand the voice, though he knows what is being discussed there, but he cannot produce the voice and tell it outside. So this is expressive aphasia. Then comes the prefrontal area. So this area, superior frontal gyrus and middle frontal gyrus. So this area is included in the prefrontal area. This prefrontal area is very much important for the personality of the individual. So where he is present, what he is doing, social awareness, ethical awareness, and judgment, whether he can do that or not, whether it is right or not, concentration, focus, everything is under the control of the prefrontal area. So if damage to this area occurs, the person loses the sense, he loses his personality, he loses the focus or attention, he loses the judgment, and he is unaware of the public also. So he may even urinate in the public places. So this is the function of prefrontal area. So all this five are seen in the superolateral surface, and there is one area called supplementary motor area which is seen on the medial aspect, on the medial surface. This is all the medial surface of the brain. So in front of the paracentral lobule you can see the superior part of the medial surface. There is a medial frontal gyrus. So this medial frontal gyrus is responsible for complex movements like attaining a posture, a standard posture, sitting posture, any lithotomy posture, or any complex posture if you have to attain. So this area helps us. So that is supplementary motor area, or this is called somatomotor area 2. Somatomotor area 2. Here the representation is not inverted homunculus, it is craniocaudal. So head will be anterior and foot will be backside. In between, trunk will be there. So when damage to this area occurs, it leads to flexor hypotonia. In the complex movements or postures, there will be good tone of the muscle, but the tone is lost. So this is called flexor hypotonia. It is bilateral, of course. So that is the supplementary motor area. Then next comes the functional areas of the parietal lobe. So mainly we have four functional areas. So primary sensory area. So this primary sensory area is present behind the central sulcus. So it is present behind the central sulcus. So this is the central sulcus. Behind the central sulcus, you are seeing the post-central gyrus. Post-central gyrus. So this post-central gyrus, and it also extends onto the medial surface, onto the posterior part of the paracentral lobule. Posterior part of paracentral lobule. And this receives exteroceptive and proprioceptive impulses. Exteroceptive means pain, touch, temperature, sensation, and proprioceptive means pressure, vibration, posture, position of muscle and joints. So this is proprioception. So any sensory information from our body mainly relates to the thalamus. So this sensation through VPL, ventroposterolateral and ventroposteromedial nucleus, they relay into the primary sensory area. So this is the primary sensory area, Brodmann's area 312. So when there is damage to this area, the patient will be unable to receive the pain, touch, temperature, pressure, vibration, or muscle, or that is extreme position of muscle or joint. that is proprioceptive and exteroceptive impulses from the opposite half of the body. So motor and sensory representation is opposite half of the body. So if right side damage occurs, there will be effect on the left side. So there is primary sensory area. Then comes the sensory association area, which we see on the superior parietal lobule. So there is a sulcus here. This is called intraparietal sulcus. So this lobe above is called superior parietal lobule, and this below the sulcus it is called inferior parietal lobule. So this superior parietal lobule lodges the sensory association area. It is responsible for stereognosis. That means when any object is kept in the hand, so the size of that object, the shape of that object, the texture of that object, and even the roughness of the object is judged by the person by just touching it. So that is called stereognosis. So when this area is damaged, it leads to a stereognosis. A stereognosis, that is loss of ability to judge the size, shape, texture and roughness of the object, or it is also called tactile, means touch. Agnosia. Agnosia means loss of sensation. So this is about the sensory association area. Then similarly we have the secondary sensory area, which is called Brodmann's area 5 and 7. 5 and 7. So where it is situated? So this is the lateral sulcus. So this is the upper lip of the lateral sulcus. This is the lower lip of the lateral sulcus. So in the upper lip of the lateral sulcus, you are seeing the inferior parietal lobule. So this part is mainly the secondary sensory area. This is responsible for pain, perception of pain. So if any person is feeling severe pain, then can this person's secondary sensual area can be ablated. Then he can lose that pain sensation. To relieve him from severe pain, you can ablate the secondary sensory area. So this secondary sensory area located on the upper lip of the inferior parietal lobule on above the lateral sulcus, responsible for pain. Then secondary sensory speech area or Wernicke speech area. So this is present in the angular gyrus and supramarginal gyrus. So this is the angular gyrus, this is the supramarginal gyrus. So which is present angular gyrus in the temporal lobe. So superior temporal sulcus curves round into the inferior parietal gyrus. So around that there will be a gyrus, that is the angular gyrus, and lateral sulcus runs into the inferior parietal lobule. Around that there is a gyrus, that is supramarginal gyrus. So these two are responsible for sensory speech, that is interpretation of speech, what they are talking, understanding of speech, anything, reading of any language, everything is under the control of this area. So when this area is damaged, it leads to sensory aphasia. Sensory aphasia, that means the patient cannot interpret the speech. So he can produce the voice, but that voice doesn't have any meaning. So there won't be any full stops, there won't be any commas, and the language is very absurd, and another person cannot understand what he is speaking. So there is no specific meaning for that language, but vocalization is present because motor area is functioning properly. So this person, he cannot read, that is alexia, he cannot write, agraphia, he cannot calculate things, acalculia, and he cannot even name the objects, naming the objects. So this is anomia. So this is about sensory speech area. Suppose There is damage to motor speech area as well as sensory speech area. Then this is called global aphasia. Global aphasia. The person cannot vocalize as well as he cannot understand, read or write anything. So this is global aphasia. Then now functional areas in the temporal lobe. So there are mainly two functional areas. One is responsible for hearing, one is responsible for keeping the memories of the past auditory experiences. So the first one is primary auditory area, that is present in the Heschel's gyrus. Heschel's gyrus. So you can see here lower lip is there. So this lower lip of lateral sulcus, upper lip is lodging the sensory secondary area. That includes in the parietal lobe, but lower lip is temporal lobe, in the superior temporal lobe. So there is one sulcus called anterior transverse sulcus here. So around in front of that you will see the anterior temporal gyrus. So in this anterior temporal gyrus you will see this is called the Heschel's gyrus. We will see the auditory cortex. Auditory cortex, which is mainly responsible for hearing. So the loudness of the voice, how loud it is, what is the quality of the voice, whether it is rough, high pitch, low pitch, everything is under the control of this primary auditory area. So when damage to this area occurs, it leads to deafness. So the patient cannot hear. So though the deafness is very mild because auditory primary auditory area receives cochlear fibers from both sides, from right side as well as left side, from the medial geniculate body. So cochlear fibers go to the both sides. From the right they go to left and right, as well as from the left they go to right and left. So that's why from the medial geniculate body, auditory cortex receives from both sides. So if one side is damaged also, there is not much deafness actually. Next, secondary auditory area. This is present around the primary auditory area in the superior temporal gyrus. So this is the superior temporal sulcus. This is inferior temporal sulcus. So here, this is the superior temporal gyrus where you are seeing the secondary auditory area or Broadman's area 21. Primary auditory area is Broadman's area 41 and 42. And this is responsible for interpretation of sounds. So from where sound is coming, whose voice it is, what is that typical sound, any sound that is cracking sound or whatever. That sound interpretation, from where it is coming, what is the quality of that sound, pitch of the sound, everything is remembered through past experiences. So that when there is damage to this area, it leads to word deafness. Word deafness means the patient cannot the words, recognize the words. Even if he is hearing the word, he cannot recognize the person. Even if we are telling some known word, he cannot remember that known object or anything. So this is also called verbal agnosia. Verbal agnosia. Loss of sensation of voice. Next comes the functional areas of the occipital lobe. So this occipital lobe has two functional areas similar to auditory area. One is primary area for vision, seeing the object. Secondary area to remember the past visual experiences. So primary area, it is present around the calcarine sulcus, around the posterior part of the calcarine sulcus. This is the calcarine sulcus. So posterior part which extends onto the occipital lobe. All this is the occipital lobe. So around that you can see one cortex. So this is called striate cortex around the calcarine sulcus posterior part. So here we have upper lip, lower lip. Upper lip receives the fibers from the lower field of vision. So fibers from the lower field of vision falls on the upper part of the retina and from there directly goes to the upper lip. Lower field of vision Upper field of vision directly falls on the lower part of the retina that goes to the lower lip. So upper lip receiving, lower field of vision. Lower lip receiving, upper field of vision. Upper field of vision. So, and from one side of the cortex, it receives the temporal fibers of the same side and nasal fibers of the opposite side. Suppose these are the two fields of two retina, and this is the field of vision. So these are the temporal fibers representing on the same side. This is one side cortex, this is another side cortex. And these are the nasal fibers which cross over to the opposite side. So one side of the cortex is receiving temporal fibers of the same side and nasal fibers of the opposite side. So this is the representation of vision in the primary visual area. So if there is any damage to this area, it leads to blindness. Blindness means not all. Suppose this area is damaged, it leads to hemianopia. Hemianopia. Homonymous, crossed homonymous hemianopia means, homonymous means, suppose this area is damaged. This part of the retina fibers receiving the field of vision, and then this part, that is medial side of the left side and the lateral side of the right side, loses the of retina, loses the field of vision. This is called homonymous. Homonymous means equal, equal parts of hemianopia. This is crossed. One side it is temporal, another side it is not nasal. So this is the effect of damage to the primary visual area. Then secondary visual area. This is called Broadband's area 18 and 19, and this primary is called Broadband's area 17. So the rest of the occipital lobe, we see the 18 and 19. So this keeps the memories of the past visual experiences. So you have seen a person some years back, you keep the memory in the 18 and 19. That is secondary visual area. And you can recognize that person. If this area is damaged, so you will forget the memory of the objects which you have already seen, or persons you have already seen, or places you have already visited. So this is the secondary visual area.